malignancy, but 13 did in the PD arm and 28 in the non-PDT arm. So cancer is an issue here, and the number one thing from this, even though this was a small series, 36% of patients develop stricture that required dilatation. This was another study that just came out in 2007 from the GI department of the Mayo Clinic, and this looked at actually patients. There was a non-randomized study comparing a PDT versus esophagectomy for high-grade dysplasia, and what it showed that 9 of the PD patients progressed to cancer, a very low rate, 6.3%. In the esophagectomy patients, there was almost 13% that had cancer at the time, and this was a lot lower cancer rates, and because of endoscopy has gotten better, better techniques or surveillance. And what they found, again, there was a high stricture rate in these patients of 25%, 12% in the esophagectomy group. And it was interesting, if you look at their overall cancer-free survival, it was similar for the two groups, but it was approaching significance that it was actually worse in the PDT group. And this didn't come out a lot, but a lot of our GI colleagues will come back to this paper saying that PDT may be better for high-grade dysplasia than esophagectomy. So in summary, for PDT, it's effective for high-grade dysplasia. Problem is it's not uniform, has a high complication rate, almost a third have strictures, and most of the time when we use PDT has been when we use it with stenting for people who have palliative, for palliation for esophageal cancer. Endoscopic mucosal resection is also gaining ground. As you know, this is a cleavage plane right below the submucosa. Occurs with EMR, and it's a very easy technique that can be done. It's a snare technique. You get a nice sample of tissue. And what is EMR, what's nice about EMR, it's the only endoscopic technique that allows a specimen for you to review to look for margins and depth of penetration. And if you look at how, the one problem with EMR is that there is not a significant but a minor complication rate. Bleeding can occur at the time, but now with different saline techniques, injection has gotten a lot less. Perforation can occur, but this seems to be less with as more experience. These patients have to continue on some type of PPIs and anti-reflux procedure. And again, you're limited in the area that you can remove with EMR. If you get greater than a half to 3/4, you can get into stricture formation, which again is around a 1/3%. This is a series that, one of the first series of EMR in 2000, it only included 9% of patients who had high-grade dysplasia, and these patients actually did very well with this. The problem is they had a recurrence of their Barrett's because nothing else was done in regards to ablation. There's another series in regards to EMR, looking at patients, and a lot of these patients had combined therapies with their EMR, such as PDT, or other therapy, and these patients actually kept in check for a long period of time. So this is gaining more ground as we're becoming more familiar with this technique. What I wanted to spend a little bit of time on is something I've been involved lately, and first of all, I have no conflicts of interest in regards to any of these procedures that we do, and this is in regards to radiofrequency ablation of Barrett's esophagus. And what this is a balloon catheter system that we use. It's in 3 centimeters in length, and what that does, it allows for a 360-degree ablation of the targeted tissue, and it's 10 joules is what the normal setting is for Barrett's, 12 joules for high-grade dysplasia. It's 300 milliseconds. It's very quick. It eliminates the point and shoot method. And also, too, because it's a very controlled depth of penetration, less than 1,000 micrograms, it prevents strictures or perforations. This is a picture of the 360 system inflated, and this is where the coils, the energy is delivered to the tissue. Also, too, if there's other areas you need to touch in regards to a small island of Barrett's esophagus, you can actually put the Halo 90 onto the end of an endoscope, and that's actually very nice for cleanup work as you come back to do repeat procedures. This is the energy generator. This has become very automated now. Use an automated sizing system. It's very inexpensive, only around $19,000 for your institution. It's very easy to use. It's all foot control, and it's become very user-friendly in the OR, not only for yourself, but also for your circulating nurses. This is just an example of this. What we do when we have a patient with Barrett's esophagus, with high-grade dysplasia, and they are at high risk for esophagectomy. We're identifying the areas with a tissue diagnosis, and then what we'll do, we'll size that area with a sizing balloon to determine the size of the balloon for maximal dilatation, so you can expand that oval structure out to maximize tissue contact. We'll instill 20 cc's of mucomist into the esophagus to help break up the mucus. And then what we'll do, we'll apply the balloon into place. You can see this through the scope, very easy system to do. Then we apply suction on the scope to pull the tissue up, very quick treatment. And what's so nice about this, you can overlap the treatment. You can overlap several areas, so you don't have to worry about stricture formation and so forth. And this is what it looks like. Here's the still pictures after. It's very easy to see where your margin of demarcation from your treatment area. This is looking down inside of the treatment area, and this is after only one application of energy. And this is another picture, one of our pictures here. This is 8 weeks after Barrex of this area. You can see a nice squamous mucosa here. In regards to clinical trials for Barrex, there's been multiple clinical trials that first started in 2003. The only ones I'm going to focus on is we were involved at Emory in the pilot esophagectomy trial, the high-grade trial, and we're actually now in the high-grade registry, and a lot of these are going on and almost finishing accrual. So there's approximately 5,000 patients in the U.S. and worldwide that have actually undergone Barrex procedures at this point. What we did, Emory, in a multi-center trial, we helped to determine the depth of the penetration and what of the RFA, and this was done when we were doing esophagectomies for a cancer. Patients had significant Barrett's or in non-Barrett's area. You can see this is a single application, a double application, and what we determined from that is that when patients received 10 or 12 joules, it completely ablated 100% of the epithelium, and it did not go beyond the muscularis mucosa. So we took it a step further. This was patients who had high-grade dysplasia within their esophagectomy specimen, and we treated again from 10 to 12 to 14 joules. And what we found is that 12 joules was actually the best. 14 joules called Moore's edema within the submucosal area, so we felt that was too high. And what we found that 9 of the 10 areas that we had ablated, that there was no high-grade dysplasia left. And the one failure was in 10 joules. So what we took home from this, and what most of the centers do, we use 10 joules of energy to treat the high-grade dysplasia. And this is a series from the Netherlands, first series that came out for high-grade dysplasia, 23 patients, ablated usually just one session, 2 areas, no stricture formation, and just an excellent response rate, 96%. Complete response to the high-grade dysplasia, and 92% for the Barrett's esophagus. Also, too, no stricture formation, and also they had eradication of genetic markers with this treatment. Most important thing, preserve esophageal physiology. There's no effect on peristalsis or swallowing with this technique. So in summary, for Barrett's esophagus, we feel that it's a very effective treatment for Barrett's esophagus and high-grade dysplasia. Stricture rate is very low. Out of that 5,000, there's been 3 cases of reported stricture formation now, but it's extremely low. It's reproducible, very effective, user-friendly. It can be done as an outpatient procedure. We do them all in the OR now, which eventually we'll be doing in the endoscopy unit, and its long-term follow-up is warranted. So the longest studies are only out around 3 years. Just real quick, and this is something I think we're doing okay on time. This is something that's not out yet. This is our new white paper from the STS on the guidelines for management of esophagus with high-grade dysplasia. Chris Fernando's been working on this from 9 institutions here, and Tom Watson, and this is getting ready. Is Hank here? I know he's here earlier, but this went back in for the final revision, so hopefully sometime later this year this will be out in press. And what they did, this was all based on best evidence medicine that was done with different levels of confidence. And this is, as we talked about, there is a section on endoscopic surveillance that this, as we talked about, should be undertaken by 2 pathologists, and that it may be acceptable for low-risk patients, others of patients with a single area of high-grade dysplasia, a flat lesion, and no complications. In regards to endoscopic ablation, they feel that photodynamic therapy, that we have the best information on that now. for that EMR can be